Thank you. With that, welcome to today's session of the Tennessee Harm Reduction Project ECHO. Today's topic is access to buprenorphine during pregnancy in the Southern Appalachia, a phone audit of pharmacies. Next slide. We have a very robust research team who are making up our speakers today. Dr. Buer is the co-founder and organizational director of Hellbender Harm Reduction in Knoxville, Tennessee. She's a medical anthropologist with over a dozen publications, including her book, RX Appalachia. Kirby is an MPH student from the University of Tennessee. His research interests lie in health equity and access to care. Previously, he interned for Hellbender Harm Reduction, where he conducted a literature review on telehealth harm reduction services for opioid use disorder and created informational materials on harm reduction strategies for gender-affirming hormone therapy. Callie is a second-year MPH student at the University of Tennessee and will attend medical school in the fall. She plans to pursue obstetrics and gynecology with a goal to specialize in maternal fetal medicine. Ella is a senior at the University of Tennessee, majoring in chemistry and political science. She plans to attend medical school and pursue work focusing on expanding healthcare in rural communities. And Maria is an undergraduate senior studying health policy and disparities through an interdisciplinary honors program. She previously worked as an advanced emergency medical technician. Marie is currently a university research assistant in projects related to HIV and AIDS, harm reduction and maternal health, and rural healthcare access. And Marie is also an intern at Hellbender Harm Reduction. Next slide. Okay, you can go ahead and take it away, research team.
Okay, I'm just going to get us started. I'm going to do a very brief introduction explaining how this research project came to be. So I was an instructor with the University of Tennessee last fall with the Appalachian Justice Research Lab. It's a really cool program through University of Tennessee that gives undergraduate, graduate, and law students opportunities to work basically a research project during the semester. Our research project was a phone audit, and it was super successful. We had a dozen students, law students, undergrads, and grad students, and they did such an amazing job. So I'm going to let Kirby go ahead and take over and tell you all about the research questions and background.
Yes, if we could, next slide, please. So we have multiple research questions going into this project. One of the first questions we considered was, once they have a prescription, do pregnant women have access to pharmacies that will dispense buprenorphine in Southern Appalachia? Next slide, please. And our second question encompassed a lot of ground in the differences in dispensing across different sectors. Specifically, we looked at what are the differences in dispensing between Appalachian counties in Tennessee and Appalachian counties in North Carolina, urban and rural Appalachia, independent and chain pharmacies, and Suboxone, which is buprenorphine and naloxone, and Subutex, which is just buprenorphine prescriptions. Next slide, please. And the last question we considered was, what is the legal and regulatory environment that contextualizes pharmacy buprenorphine dispensing in Southern Appalachia? And for this, we looked at current conscience laws, DEA and FDA policies, state pharmacy board policies, and similar policies in this realm. Next slide, please. And then we wanted to provide some context on the background information that we found in existing literature. Next slide, please. So first, we noted that Appalachia has higher overdose rates compared to the rest of the US. We also noted that medications for opioid use disorder, or MOUD, is the gold standard for care, especially for people who are pregnant and using opioids, as this MOUD reduces the risk of overdose and HIV while improving pregnancy outcomes. We also noted that state-level regulations that govern buprenorphine limits the number of patients who can receive it. And lastly, barriers, which include wait times and refusals from pharmacists, are often connected to stigma and concerns about regulations. Next slide, please. And we wanted to highlight, we created as part of this project and are in the process of refining two one-pagers. This first one, the intended audience is pregnant women who use opioids, and this fact sheet is intended to describe what buprenorphine is, to clear up some misconceptions, add advice for how to navigate care, and explain potential disparities. And if we can move to the next slide, please. And lastly, we created the secondary one-pager, which focuses as its audience pharmacists themselves. And in this, we describe what is the difference between Suboxone and Subutex. Here's the specifics on how buprenorphine is safe during pregnancy. And here's what they can do as pharmacists to increase accessibility. And if we go to the next slide, please.
So we did have a team of law students working with us, and they were evaluating mostly just what does the actual law say about buprenorphine, and then how does that law create incentives for providers that impact the patients. Go to the next slide if you don't mind. So the main things that you need to know, number one, buprenorphine is a Schedule III substance and it is federally regulated. The verbiage for that is a moderate to low potential for physical and psychological dependence. And it mostly just regulates how it has to be prescribed and then the amount of time that you can have before the prescription has to be sent in again. But there are also specific state laws that can govern it specifically. So Tennessee has one that allows for the use of monobuprenorphine without naloxone, specifically in cases of pregnancy. So it's just important to note that there are like federal and state laws that can both impact it at the same time. And then we also have the new Tennessee Medical Ethics Defense Act. And the important part of that is that pharmacists can refuse based on their religious, ethical, or moral objections. And there are very few actual definitions written into this act. And they also don't have to disclose the cause of their objection. So of course, as it would be expected, this is creating a lot of additional barriers. You can move on. Thank you.
Okay. Can everybody hear me?
Yep.
Okay, great. My name's Callie. I'll talk about the quantitative analysis and just our methods as a whole. So if you want to go to the next slide, please. So we started by looking at the Appalachian Region Commission to identify the counties that we wanted to look at in Appalachia, since that was the goal of our study. And we narrowed into the 52 counties in Tennessee and 31 counties in North Carolina that were considered part of Appalachia. Now, some of those might be rural versus not rural, as Kirby alluded to earlier. And out of those total, we identified all the pharmacies that we could possibly call. And in Tennessee, we had 672 pharmacies possible to call. And in North Carolina, we had 404. And a little bit of background on what we actually did was we had a script and we had multiple callers, and we would call these pharmacies that we were able to, and a certain amount per week, and we'd follow the script. And it was basically the time of having a prescription to asking about when it could be filled, if it's possibly to be filled. And there were multiple things that came from that. So next slide, please. So the way we chose to sample was we call a bottle fill approach. So we wanted to ensure that every county was represented. That actually was sometimes more difficult than you would think. Some counties have one pharmacy in it, some counties have tons. And we really wanted to ensure that at least if we could, one chain and one independent. So you might think of like a CVS or a Walgreens versus an independent, like a mom and pop shop maybe. And we strived for a sample size of at least 300 pharmacies, and that was completed calls. And I want to stress that these completed calls don't just mean like we typed in their number and called. Completed means that we actually got to speak to the pharmacist that was on staff that day and be able to go through our script. Whether or not we got shut down, yes or no, it didn't matter. We completed that call. And so our final count among us was 347, with 210 being in Tennessee and 137 being in North Carolina. Next slide, please. So breaking that down further, the calls that we actually completed. So the rurality is that rural versus not rural. For example, Knox County was included in Tennessee, and it's not all rural. So in Tennessee, we had 71 not rural with 138 rural. In North Carolina, we saw similar amounts of more representation of the rural counties being in Appalachia. Under the facility type, like I said, that chain versus independent, we called more independents in Tennessee. We were able to talk to them a lot more. Sometimes chains are difficult, like with an AI line to get in. That was a barrier a little bit in Tennessee. In North Carolina, we actually were able to call more chains than independents. And then the formulation of Suboxone versus Subutex was randomly assigned to each call, but we tried to keep them relatively similar amounts. You can go on to the next slide, please. Sorry if you hear anything. I'm taking this from my clinic. But the questions we looked at that we actually ended up running statistical analyses on was, are there any differences in dispensing between states? So that was, I would say, one of our primary focuses was, what's the difference between North Carolina and Tennessee? And we actually found that there was a significant difference where Tennessee is much more likely to not fill those prescriptions for whatever reason that may be. But the graph in the middle, you'll see Tennessee is much higher with no, will not fill, and also is higher in other, but it was significant. Next slide, please. We then looked at the difference between pharmacy types. So that's facility type. So we talked about chain or independent. We found that independent actually significantly filled fewer prescriptions. That's even adjusting for state differences. So throughout both states, they did, independents did fill, but they didn't fill at a greater rate, at a more significant rate than chains. And a lot of that will be noted in our qualitative analysis of maybe some explanations or reasons why that might happen. We got a lot of different reasons on these calls. Next slide, please. And then the last thing that we looked at, the question that we looked at was the rural versus not rural, right? So we did not find a significant difference based on rurality. And we also did not find a significant difference based on formulation type. So that was really interesting. And I forget exactly how we talk about it in the qualitative analysis because we did this presentation a little while ago, but as a caller, it was super interesting thinking that maybe people would be more favorable to one versus the other and almost getting completely different answers virtually every call. Oh, Suboxone's a lot better, Subutex is better, I recommend this, I recommend that. It was very different. And so there was a clear, I think, gap in information there, even from the pharmacist level all the way to my level. Next slide, please. I'll pass it over, I think, back to Marie, right? For qualitative.
Yes. So for qualitative, we were mostly looking at our actual call notes and then some of the responses that we got as we asked like for explanations to the pharmacist. So for the first slide, we had a lot of surprising pharmacists who genuinely just didn't have the form that we needed. I know that I was really surprised by that, but I think a lot of us expected that they would just immediately say, no, of course not, you can't have that. But a lot of them genuinely just didn't have it. So if we were requesting Suboxone and they only had Subutex, they would say like, oh, I haven't had Suboxone in years. Like there just was kind of a random distribution of who carried what. And then there were also a ton of policies related to how many patients they could have on buprenorphine, or if they were able to put patients from different counties on it. So a lot of them would ask, like, are you local? Is your clinic local? And then they would say, well, we can't accept new patients, but we can still fill it for other patients who have already started filling here. And then some of them genuinely just asked a lot of information. They asked about our insurance, our history, like substance use history, things like that. And the next slide. There was a lot of use of the risk versus benefit logic, and this was actually articulated. The pharmacist would say, well, you just have to weigh the risk and the benefits. So they would address a lot of concerns related to the safety of the fetus, saying that maybe they would have to be tapered off after they were born, or there was a concern for low birth weight. Not many pharmacists actually mentioned the risk of not being on MOUD while pregnant. Most of them were actually more interested in the risk of being on it. But there were a lot of pharmacists that stated a preference for the Subutex, the single formulation buprenorphine, in cases of pregnancy for safety. which was good. And then I think we have a quote for the next slide. So yeah, this was just one of the examples. They just said, they explained that the benefits outweigh the risk being overdose or something else harmful to the baby, and then it's considered safe if you've weighed that. And then there was another pharmacist who told one of our callers that the baby will likely need to be in the NICU and be born with an addiction to Subutex, but they will taper them off. So there was just a lot of concerns regarding the safety kind of being thrown around. The next slide, I think, is Ella.
Yes, so another theme we saw was the theme of research and referral and the assessment of safety. And this kind of encompassed a few different categories. So we saw pharmacists frequently discussing research or even conducting research during the phone calls. We also saw pharmacists that frequently indicated the importance of involving a medical provider in the final decision, whether this was the OBGYN or a PCP. And then lastly, we also saw pharmacists that requested a specific documentation from the prescriber before they confirmed if they could give us the medication or not. And then if you don't mind going to the next slide. And a quote from this was, a pharmacist said that he cannot say any drug is 100% safe for pregnancy. It would be up to my healthcare provider to decide whether the benefits would outweigh the risk in this particular situation. And then the last theme we saw was the general theme of tone and attitude. So this encompassed some pharmacists that provided encouragement, support, and exceptional advice. And then on the other hand, we also had pharmacists who had negative or dismissive attitudes during the phone call. So this included answering questions dismissively, hanging up the phone mid-call, providing inaccurate or stigmatizing information, and groaning or sighing. And so we have a quote showing some of the positive attitudes and themes. And this was a pharmacist saying, "Do you mind if I go do some research and call you back?" She called back a few hours later, confirmed my name, and then told me she did research and called her own OB to be sure she was correct. Another pharmacist was very passionate about me starting Subutex, and he said good luck at the end of the call. And then if you'll go to the next slide, please. And then this is an example of a negative attitude we encountered, and the pharmacist groaned when I said I was pregnant. Also, while she was checking stock and looking up information on Subutex, I was on hold, and she muttered to herself, "I'm sure it's contraindicated, and I can't believe it's safe for a pregnant woman."
Yeah, so I'll bring us back a little bit. And I think some of the qualitative and quantitative shows us a few things. And one, it's what a powerful resource pharmacists can be in communities, especially in small communities and rural communities. I mean, calling your own doctor and doing vast amounts of research and then calling someone back is, it's a level of you're a huge community resource. On the other hand, we can also see what a huge source of stigma pharmacists can also be. And I know I've accompanied a lot of folks to pick up their prescriptions, especially when I was working in rural East Tennessee and rural Kentucky, Eastern Kentucky. And you see it on people's faces. You see people's faces fall when they have to engage with the pharmacist who is being stigmatizing. And that's sort of what led to this research in the beginning. But I think we know that there needs to be a better training for pharmacists, and also we could have so many improved policies, both the pharmacist level, the prescriber level, to increase access to buprenorphine. In Tennessee, we know Medicaid expansion would do that, but that seems a very far-flung hope of anything right now. But one significant thing I did want to talk about that could be a possible reason because the differences between Tennessee and North Carolina is in the last few years, North Carolina has done an enormous education campaign of pharmacists around MOUD and pregnancy. And so I think this study is it's possibly showing what that training over the last few years has done. And so I think it's, again, we can't overemphasize training. But I think we have taken up our 20 minutes, and of course, welcome questions, and then we'll also have some scenarios.
My goodness, thank you so much, you guys. That was so, like, obviously I saw the slides beforehand, but I didn't get all of the context, and so I loved hearing about this. If anyone has questions, you can totally put them in the chat. You can raise your hand and unmute. We also have the anonymous Menti link if that's what you prefer. Elliot in the chat, just FYI, here's a presentation overview of our 2022 Tennessee-specific secret shopping study results, where we found that less than half of Tennessee pharmacies would be able/willing to fill a new patient's buprenorphine prescription. That hurts, Elliot. Thank you for sharing. And we'll definitely include that in the resources after the call. We have a question in the Menti for our speakers. Why is Subutex preferred?
So previous research from the 2010s had shown slightly better outcomes for Subutex, and so I think some pharmacists are still in that, but more recent research has shown that for outcomes for both the pregnant person and neonatal outcomes are very similar between Suboxone and Subutex. So sort of that preference for Subutex is based on some older research.
How can we as medical providers help our patients advocate when talking with a pharmacist, or is there another role we can play?
That's our scenario. I don't know if you want to wait for that question because that is like our sort of scenario question.
Yeah, that's true. We could wait for the scenario. Okay, any last questions before we move on to the scenario? Because that would also be a great segue.
I apologize for being a little bit late, but is there a link to
Go ahead.
see your results or data?
We hope to have we will have one-pagers on our website by the end of our student semester, and then we will have a publishable paper going out for review by April.
Great. I just would love anything you guys are able to share. I appreciate it.
Okay, Allie, you can move on to the next slide, and I'm actually going to pass it to Rebecca once you stop the recording.